You're listening to Innovators, the podcast from Harris Search Associates, where we speak with global leaders in education, research, engineering, and the health sciences, and ask them to share lessons learned as they continue to advance the frontiers of innovation and discovery. Today's podcast will be led by Rick Skinner, Senior Consultant. It's easy to forget that the use and misuse of opium dates to 3400 BC in Lower Mesopotamia and did not become prominent in America until the mid-1990s. Even so, the American opioid crisis is striking for at least two reasons. One, its staying power, more than 30 years at this point. Drug epidemics usually ebb over time as users die, people shun drugs after seeing their damage, and users move on to other drugs. The second distinctive feature of the opioid crisis is its lethality, with deaths involving opioids rising from nearly 20,000 in 1999 to almost 82,000 in 2022. Just recently, however, news arrived that overdose deaths declined in 2023. Does that mean opioids are following the path of previous drugs and fading away, or is this one-year decline simply an aberration, a respite from a worsening crisis? This installment of Innovators considers these and other aspects of the opioid crisis with an expert in the field. Jennifer Sharpe Potter is a nationally recognized addiction researcher. Her work focuses on the prevention and treatment of substance use disorders, with an emphasis on opioid use disorders and chronic pain in civilian and military populations. She has led or participated in research projects supported by more than $56 million in grants from the National Institutes of Health and other agencies, and that research has yielded more than 200 publications. Born in Canada, Dr. Potter earned an undergraduate degree from Queen's University, a master's degree in public health from Emory University, and a doctorate in clinical psychology from the University of Georgia. She completed a pre-doctoral internship and a post-Ph.D. research fellowship at Harvard Medical School and McLean Hospital, where she worked until joining the University of Texas Health Science Center at San Antonio. There, Dr. Potter rose through the ranks to full professor, and in 2021, she was named the institution's vice president for research. Dr. Potter's accomplishments are indeed numerous and wide-ranging, and we are delighted to welcome her to Innovators.
Whether or not the 2023 reported decline in deaths from opioid overdose in the beginning of or is the beginning of the decline of this terrible trend, that's going to be answered by next year's data to some extent. But I guess the question I'd like to start off with is, do we really know what the full dimensions of the opioid crisis have been and are? For example, its origins really were as a very powerful way to deal with pain. And it was seen as an extraordinary opportunity. Then we had the period when remarkable marketing efforts by drug manufacturers went into place to increase the prescription of those drugs. And then almost immediately thereafter, or very soon thereafter, we have the spread of opioid abuse throughout the population, not simply in some one group. Are all of those attributes now clear? Do we now have a clear sense of what the landscape is? And could I ask you to talk about the landscape? Do we understand this phenomenon in all its dimensions? And the reason I think that's so important is because where we are now is we may have a chance to do something really important about it. So can you sketch out that landscape now?
Sure. Well, thanks for having me to talk about this really important topic. And I'll start with yes and no, which is not a very helpful beginning. So on the one hand, I think because we have better data now, we understand what's happened. We understand the ebb and flow, and we know the arc of opioid related overdose deaths. But what we haven't reconciled, I would say, is that while we know that it began, as you articulated, with a very noble intent, and I would say providing pain relief, pain is one of the biggest complaints that people have, and being able to provide good evidence-based, science-based approaches to that is critical. Somewhere along the way, we went wrong. Where I differ slightly with some of the contemporary discussions around this is on two things. We are now no longer, and this is inarguable, struggling with prescription opioids. Right now, what we are contending with, and it often gets confused by policy and by providers, is we are struggling with what we call the fourth wave of the overdose crisis. And that crisis is really related to contaminated drug supply in the United States that is contaminated by illicit fentanyl. This is not the fentanyl that somebody might get in the context of palliative care for cancer. This is illicitly manufactured fentanyl that has contaminated the drug supply. And we're also dealing in the recent decline, 3%, only 3% decline, and those are all real lives, so that's very good, overshadows a little bit that actually methamphetamine and stimulants related overdoses actually increased. And so you started with opioid crisis, and that's a term that a lot of individuals use. I tend, and my colleagues tend to prefer overdose crisis because we want to understand drug use in its entirety. The good news about what has happened, and it has been catastrophic to our country, but one ray of light is the light that it has shined on substance use in America. But we still are struggling with how to contend with that. It's been so focused on opioids that we forget there are a lot of other substances, including alcohol, by the way, that continue to be a scourge. People use drugs, people use alcohol. We still haven't reconciled that fact. And sometimes it's easier to focus on fentanyl as a topic than to really say, let's have an honest conversation around drug use in America. What the science tells us is the best way to address it. And arguably to shift a little away from supply side control to drug use is normal. It's endemic in our culture. So what do we do when people have problems? Because not everybody does, but how do we make it safer in some ways to help people along that journey not die, and then provide them with the very best care? There are still major swaths of the United States where science-based practice, because we do know what to do, science-based practice has not been deployed. And that's really where a lot of my work is now, is less out of a heavily controlled, randomized controlled trial. But look, we know these things. We have X, Y, and Z. We have medication. We have behavioral treatment. We have motivational incentives to help people and reduce morbidity and mortality. Why aren't we using those? And what are the contextual factors that are interfering with our ability to help the moms that I meet that have lost children, to help, the 35-year-old gentleman who's just failed to launch because of chronic marijuana use, which, by the way, is also a problem in the United States.
Yes.
And so I hope that helps a little bit, is we don't know how to reconcile all of this. And at the end of it, underlying it is our entire historical approach to substance use as a character disorder, the disenfranchisement of substance use disorder treatment from mental health care, and the stigma that has contributed to and leads.
So that's a cultural thing. That really is a more fundamental cultural thing, to see drugs or substance abuse as largely a failure of character or morality or something like that. What I hear you saying, it's interesting. You're convinced that there are practices now that could deal with this problem. And let's not call it a crisis for the moment. Let's just call it the problem.
Mhm.
And you're also suggesting that there's a certain kind of, I don't know what others call it, but a hypocrisy to our approach to drug use, because drug use is endemic. It's all around us. It's something that happens every day in our life. And yet by seeing it as something aberrant, we fail to address the problem. And am I right on that?
I think exactly right. There are a number of us, and I say this a lot, is that unlike the pandemic and COVID, where we had to find a cure, we had to figure out what to do, we had to find a vaccine, we had to find a medical solution. With opioid use disorder, we actually know what to do. We just didn't do it, and we didn't deploy it in sufficient way to mitigate this. And again, think about this. Just my context is that the conversations that I see now and over the last 10 years were things we saw coming in the early 2000s, in 2006. The largest study examining treatment for prescription-related opioid use disorder was published in 2011 with effective results. But we didn't start seeing this in the landscape, really talking about it until 2016 and beyond. And so that's why I would call it the greatest public health failure of our time. I mean, or one of them, because we know what to do. We didn't do it.
So what's implicit in what you're saying is, I think I understand this, that there was a point in time when if we had been willing and able to bring what we knew to bear,
Mhm.
this terrible scourge may not have been avoided, but at least it would not have turned into this roaring pandemic that we seem to be doing. You're actually suggesting we had the means to do that?
Yes. So, and I'll give you a very concrete example. So
Please.
buprenorphine is an FDA-approved
Yep.
medication. It's a partial opioid agonist,
Mhm.
and it was approved 2001.
Wow.
We were talking as recently as, well, we still talk about it. There are still papers coming out examining access to buprenorphine. And the beauty of buprenorphine as a treatment solution, and this is before what I would call the first wave, in some ways, of the overdose epidemic or the opioid issues that we're dealing with, was that it could be prescribed in an outpatient setting, meaning it was not a methadone program, which is a
Mhm.
highly regulated,
Yep.
federally monitored,
Mhm.
very structured
Mhm.
treatment, which has a place. It has a place in our treatment arsenal. But buprenorphine afforded us the ability to make opioid use disorder treatment simpler for a subset of the community and the population with this disease that could benefit from a lower level of care while still getting the only evidence-based practice to reduce morbidity and mortality, which is medication.
Nation.
And I say that as a psychologist who believes in the power of behavior and behavior change. But I am convinced, and the data tells us that medication is the standard of care.
Gotcha.
That was 2001. How long have we spent? For those of your audience that knows implementation science, this is a failure of implementation. And this is why implementation science and some of these fields that are looking at what is the barrier? Why does it take 20 years for an innovation, a therapeutic in this case, to be deployed in a way that's accessible to people? And if we had done that, if it had been more rapidly, if the uptake had been more rapid, and we understood how to more rapidly get this into the at that time, the mouths, literally, because it's delivered sublingually at the time, of patients, we might not have in the same way a fentanyl issue that we're having. So it is very real to say that it is cost us lives in the United States.
That's at once enlightening and frightening at the same time. Do you have a sense of why implementation has taken so long? Is it something in the way in which we view the problem? Is it something in the way we try to address the problem?
Yes, we do know, and we have a really strong sense. So it's just some examples. For example, there's research, this is well published in the literature, when you speak, one of the ideas was that we should have more primary care intervention. Just like you can be treated for cardiovascular disease with your primary care provider, and go see a specialist when you need to see a specialist, or a consult with your primary care provider. That was the vision. That was the hope. Could we normalize relations between addiction and primary care? And that was unconvincing to the primary care audience, because from my perspective, we failed to create that system of care that gave them a level of confidence that they could do this. So from the literature, we know that primary care providers don't want those people in their clinic. They don't want to turn into an addiction clinic, because addiction clinics are places that only treat, and I'm going to use this stigmatizing word intentionally, addicts. And yet we didn't provide the tools to say, no, 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 that's not what we mean. Let us help find a solution. And there's a lot of reasons why that is. I think it's access. I think it's the number of professionals that want to work in the area of substance use. And the good news is that's changing, because many of those individuals have been directly impacted in their lives by this and are thereby motivated. It's one of the sort of perverse positive outcomes
Exactly.
of a public health crisis. And it's stigma. It's stigma in our profession, not just of patients that have an opioid use disorder or another substance use, but concern that you are stigmatized by your peers. Why are you treating those people? And so those were barriers. Another barrier is medical legal risk. Providers are concerned that the DEA will appear at their door and they'll get shut down, which is, it doesn't happen in the way that people worry about, but we have to help with that. And we dropped this medication into our ecosystem of healthcare and said, ta-da, it's approved, it's going to work, go forth and prosper. And that didn't happen. And it took a long time, a lot of death, and we played catch up.
That part, does it also explain to some extent why, if one goes looking at children's hospitals or places that's focused on OBGYN, that you often will not find anything on a website or whatever that talks about women who have substance abuse problems. And therefore, those women will not seek out care prior to their giving birth. Is it the same stigma and this unwillingness to be identified with what is seen as a problem or a bad thing? Is that part of this?
Absolutely. I mean, you've hit the nail on the head with that. The best evidence we have continues to suggest that one of the major reasons people don't talk to their healthcare providers about substance use is because they are afraid of stigma. They are afraid. That's one reason. They also don't know, because of some of the ways that we talk about addiction, that it's okay to talk to your doctor about this, that it's a treatable condition. And you actually should. It behooves the provider to be able to have good options for you because it is so common. So yes, so for women, that's even more stigmatizing. There are parts of the United States where a parent could lose custody of their child because they are asking for help. And that's very real because we want to keep children safe. And we also know that when people are treated for their substance use disorder, that increases the likelihood of the parent-child reunification. And these are the stories that we try to elevate because, stigma is very hard to combat. How do you make something go away like stigma? What we need to do is change our systems to be stigma-free. New ways of doing things. So we're moving towards positive behaviors as opposed to trying to eliminate these negative behaviors. And so in what we do, we spend a lot of time, we don't spend dark, bleak, we don't create dark, terrifying stories of heroin addiction. What we work on is showing stories that, yes, it was hard. Yes, it is difficult. And yes, we lose people, but there are positive images in what we do because we want to demonstrate that we want you to come forward. I have a program called Be Well Texas. And on our tagline is, welcome to Be Well Texas. We are glad you're here. And the reason we have that is we want to know everyone is welcome. Everyone needs to come through our door knowing it can be serious, it can be hope, it can be all of those things. We take it very seriously, but when you walk through our door, when we answer our phones, our values demonstrate compassion, welcome, and judgment-free. It doesn't mean it's not a hard road. It doesn't mean that people have to take accountability for their actions. But it does mean we want you to feel like you're going to the doctor and someone's going to be there to go, how can I help? Thank you for coming to the doctor. Thank you for doing this screening. This is exactly where you should be, and we're here with you. Because we don't want people to not come and seek help, because the consequence of that could be death. Because make no mistake, and people don't talk about this enough, substance use is a life-threatening disorder, and it should be treated with the dignity and concern and gravitas that all other diseases like cancer are treated, because people can lose their lives.
And what strikes me is the stigma problem, the problem that stigma brings to all this is that it not only pervades the popular culture, but as you're suggesting, it pervades professional cultures also. And therefore, the very things that we might turn to are themselves averse to dealing with it on those terms.
Yes.
I guess that leads me to sort of ask another question, that we now have these settlements between both retail pharmaceutical firms and the actual drug manufacturers themselves. And the sums of money are enormous in some cases, and of course, there's still challenges and so forth. But it does appear as though there's going to be a considerable amount of money out there. I guess the question I have is that at this point, do we have enough data to say what that money is being used for? Is it being used, for example, for services, or is it being used primarily for research, or is it being used for whatever purpose? Do we have some sense now that, knowing what we know now, that we're using the funds, the resources that are available to actually bring about the change that you're describing that could actually deal with not only this problem, the problem of opioids, but whatever the next one is that may come our way? Is there any sign of, in your eyes, that tell you how that money's being spent?
There are signals, and certainly I can't speak with expertise to everywhere in the United States,
Sure.
but I'll preface this with, at least in the Texas environment, there was concern that based on the experience that some communities felt with the tobacco settlements,
That's exactly what I was thinking of.
yeah, that some of that money felt like it was not transparent.
Mhm,
And so did it actually, the communities, largely speaking, thought that that should go towards addressing
mhm,
the downstream consequences of tobacco use. I think in all of the interactions that I have had, in varying ways with individuals, both at the government level as well as some of the council that worked with the settlements, I
mhm.
think it was very pervasive in the conversations about modeling this based on what it's going to take to treat. What are the services we
Ah,
need? And so it did have that feel of that. And I will bear out with you, and I'll just give some local examples. Again, these are anecdotal because of that, but
sure.
my observation has been in Texas is the way it's been structured, it is intended to go for programmatic work. So for
Mm,
example, through the Texas legislature, we have approximately $18 million of funds specifically to distribute naloxone. And so
Very,
right
very good.
now, that's no cost naloxone being distributed in all 254 counties of
No
Texas.
cost, no cost to the
And that's no
individual.
cost. And that combined with some of the federal dollars that come to
Mhm,
Texas allows us to push out about $1 million in naloxone throughout the state,
great.
specifically targeting groups and entities that are most likely to be adjacent to a person at risk for an overdose. And so
Mhm,
naloxone is an opioid reversal agent
mhm,
that can reverse an overdose. And
mhm,
so that's that money going to work. The city of San Antonio, with their abatement money, just recently announced programs that were very specifically related to that. And then we actually, and again, I'm just using our programs as examples, but we just received several $1 million, or we're in contract, but it's been announced to help in San Antonio with two things: building a recovery community organization. That's a peer-led program to build a positive environment for individuals in recovery, to build community and affinity and continue their journey of recovery,
mhm,
as well as a project we're very excited about, which is mobile outreach going into encampments, individuals who are experiencing homelessness
mhm.
and unhoused, to provide them with treatment where they're at. We're doing this with our physicians actually in second place, with the street outreach workers leading, where
Fascinating.
we humbly follow, because the people that are trusted are our outreach workers. And then we actually have been able to leverage a good news about the electronic health record. I have a happy story.
Wait a minute, this would be a first.
Yes, exactly. So we're actually Epic in a backpack. So actually, our electronic health record is going on the road with us, so that our providers can actually be where individuals are, to start to build that trust and to encourage
Mhm,
individuals to come on to
mhm.
treatment. So I think those are really good examples, and I know others of very concrete, responsible uses of those funds.
So we are starting to see, we learned something from tobacco perhaps, and we're starting to put it in place. And I guess it is encouraging to hear that we are taking the approach that, rather than keep the community away, the community of people who are suffering, we've actually embraced them as part of the answer.
Mhm.
You know, I think you've given at once a very very complete and somewhat intimidating picture. And at the same time, it does sound like we're seeing some islands of hope and some islands of possibilities. I guess that leads me to ask a final question that puts a lot on you. If if we were to, at this early stage that we're putting resources to bear, are there some lessons we could glean for whatever's coming next? And here's the reason I say it. Fentanyl is a drug that can be created in somebody's bathroom almost. I mean, that's a little exaggerated, but there are going to be new drugs. There are going to be other threats and the problems that come. What are the lessons we ought to come away from this experience of the last 30 years? And it has been 30 plus years now. What should we come away with? What have we learned that would help us to move forward?
I'm going to start. I feel like I'm being very unscientist about all of this. So I'll go back to some science, but I'm pretty bullish on hope right now. And in answering the first part of your question, I want to go back to the last question, because as much as I say all of these challenges about how we got here and what we're still struggling with, the stories of hope that I see are actually, that expression, there's a crack in everything, it's how the light gets in. So
Exactly.
the light that I see, I have medical students now who come to us and say they want to work on our projects because they're in recovery. I have medical students now who come and say, I lost a brother or a sister or a father, or a family member. Those are tragic stories of loss. On the other hand, I have a medical student, more than one, who wants to work in this field and work in the field of addiction and help because they're in recovery. That is not a story that individual would have felt even remotely safe talking about, except the very unusual person,
Yeah, very unusual.
even 5 or 10 years ago.
Oh, for
So
sure.
this willingness to put your story out there and to talk about this, and to not just talk about it, but to go into fields that can be impactful, gives me tremendous hope. I am seeing changes in hospitals because the residents who are now there are demanding new standards of care. There are folks like me who spend a lot of time very intentionally mapping out projects, but the structures and the systems and the training that collectively we have been doing is actually meaning that we have many, many champions. It's not just me. There's a megaphone on people wanting to do this because culture can change. And because this is apolitical. This is about communities across the United States seeing a deep commitment to saying we have to do something different. And so again, it's on the shoulders of many people who have lost their lives and families that are devastated. And I can't forget that. But I also see structures that I thought I couldn't change by myself, which is a very marvelous thing to think of oneself, but they're starting to change. It's so much easier to walk into a room and talk about the science. So I'm going to shift now to the other part and answer with a science question. The other hope that I have is that in many ways, as much as I've said there are places where science is not deployed and we don't use evidence-based practices, I am in a state, for example, that many years ago did not really have an evidence-based treatment infrastructure. Resources, federal dollars were deployed and given the opportunity to work. And our state across the board recognized an opportunity, partnered with a state institution, also a university that's state funded, and changed that. And we now have an environment where science is actively being deployed in the form of evidence-based practices to treat in ways that never happened before. So the answer is to keep doing what we're doing and not pull back, because methamphetamine continues to be an issue. And it's going to be a test, because if we thought opioids were a stigmatized issue, methamphetamine is very much that. And it is a very damaging, destructive drug to use. But the science is there. We have multiple drugs right now, alone and in combination, as well as devices being tested for treatment. So let's not do what we did. Let's not take 20 years. Let's study now how to implement, know what the marketplace looks like, know what providers and patients care about. So when we have this next evidence-based practice, we're reducing that latency between when we have the innovation and when we deploy. And that is public-private partnerships. that is embracing innovation, it's listening, and it's doing that type of work. And we have funding now that's doing exactly that. So we're ready to deploy innovation more rapidly. We are looking at companies that partner with us around devices. That's my hope, is that keep our eyes and don't play substance use whack-a-mole. Think about this holistically and continue to press us on where we're going to go.
What really comes across in everything you said today in this brief time together is a kind of realism to me. And I want to compliment you for that realism. It's hard to turn tragedy into something hopeful. And yet in some ways, what you've described is the tragedy is as much not just the loss of lives and the destruction of families and communities, but it's also the fact that we could have done a little better than we did, except for some values and attitudes that we have. You said it best a moment ago when you said to me, culture can change. And
Yeah.
it sounds as though when that medical student comes in and says, I lost my sister to one of these drugs, I want to know how to make sure that doesn't happen again. On behalf of all of us at Harris, I want to thank you very, very much, not only for today, but for the work you're doing. And we want to especially thank you for taking time to be on Innovators.
Well, thank you so much. It was a pleasure.
Thank you for listening to Innovators, a production of Harris Search Associates. We'll have more insightful conversations with global thought leaders to follow.